Healthcare system financing issues and trends. So here's a question for you. What are the 3 types of government-sponsored health insurance plans, and who is covered by each plan? And here's your answer. I will let you read through that one on your own. So another question is how do problems arise within quality, service, and cost in health care? And again, there's your answer. And I'm going to let you read through that one also on your own. Here's some basic healthcare insurance terms that you really need to be familiar with because, insurance is a language in and of itself. So in the United States, the healthcare system is really not organized very well, and there's a complicated maze that we have to navigate through. One of the most important things for you to be familiar with these days is the Affordable Care Act. And you may be relatively familiar with it already. It was signed into law in 2009, and it's the first piece of legislation that has actually addressed healthcare reform since 1965. The 2 most common ways to finance healthcare services are fee-for-service and capitation. Fee-for-service is the traditional method of paying healthcare bills. It's where the physicians are paid by the client for each service. In fee-for-service, the insurance companies will charge deductibles, co-payments, and co-insurance. Pros for this type of payment is most tests and treatments for illnesses are covered. But the cons are there is more of an emphasis on illness, deductibles, and co-payments, and these keep the clients from reporting illness in the early stages. With capitation, there is a set monthly fee charged by the provider for each member of the insurance group for a specific set of services. This is managed care, such as HMOs and preferred provider organizations. If healthcare costs more than a monthly fee, then the provider will be the one to pick up the cost. Pros for this type of service is wellness is encouraged to realize a profit. With cons, there are no deductibles or copays to realize a profit, so there's a lot of tests that may not be ordered that really should be. So how do patients pay for healthcare services? Let's talk about each one of these separately. We've got the personal payment or private pay, where the payment again is made directly by the client. Some clients may use this method of payment still today. Cost of healthcare services discourages the use of this method though. Private pay clients may be able to negotiate a discount with some healthcare agencies. Private group health insurance pools individual contributions for a common group goal. So there's protection from financial disaster such as a result of healthcare bills. It's offered by most employers in the United States, and no member is denied coverage based on their past medical history. Examples of private group health insurance will include like Blue Cross and Blue Shield, indemnity policies that are issued by commercial insurance companies, and health maintenance organizations. Private individual or non-group health insurance is offered by insurance companies to individuals that are not part of a group, and people can be insured without employment. The cost is generally higher than for group plans. Premiums are based on a person's health risk and their age. Young and healthy people generally subsidize or support financially the sick and older people in the health insurance group. Those who are likely to have high medical bills are often denied coverage. Administrative costs of private health insurance can run up to 31% of the premiums. Medicare is a program of Social Security. It's federally sponsored. It's an entitlement program and public health insurance plan. It helps finance health care for all persons older than age 65 and their spouses. You have to have at least a 10-year record in the Medicare-covered employment to qualify for Medicare. So being privately employed, it may not, there may be some issues there. You must be a citizen or a permanent resident of the United States to receive Medicare. There are several different Medicare plans available. Again, these are funded by the federal government. Part A is hospital insurance for inpatient hospital care. Part B is medical insurance for physician services, outpatient care, and diagnostic tests. It's the 80%, 20%. Part C is the Medicare Advantage plan that's offered by private insurance companies, and it's usually geographically designed. Part D is the Medicare drug legislation that provides prescription drug coverage. Medicare does not cover everything, so beneficiaries are encouraged to purchase supplemental coverage. Diagnosis-related groups, or DRG systems. This is where math formulas calculate the fee that the government will pay for the hospital for each hospitalization per illness. So in other words, they get the same fee despite the number of days that the client stays in the hospital. So if an older person goes in and they have a cholecystectomy, their gallbladder is removed. Well, one person is in and out in one day. It's an outpatient procedure. Whereas another person had complications and they ended up with an infection and they end up staying in the hospital for 2 weeks. The fee is going to be the same irregardless of the length of time that the client stays in the hospital. Medicaid, or medical assistance, is for eligible families and individuals with low incomes and resources. It's a cooperative venture between federal and state governments, and it has broad national guidelines. Each state will establish its own program services and eligibility requirements. There's also the Children's Health Insurance Program, or CHIP, that covers uninsured children up to 200% of the poverty level. Again, it varies from state to state. A person may qualify in one state, but they won't qualify in the next state. And the services do not cross state lines. We know that health insurance costs have continued to rise, and that increases the costs that employers are required to pay. Starting in 2014, citizens and legal residents must obtain health insurance or they have to pay a penalty. People would be exempt if they would have to pay more than 8% of their income, low income, religious exemptions, undocumented immigrants, they're incarcerated, and American Indians. So traditionally, who were the uninsured? Well, we know that these were the low-wage employees and the middle-class workers. Alternatives to pay for health care include Medicaid if they qualify, private pay if they can afford it, charity care if they can find it, or they face medical bankruptcy. A lack of access to health care prevents individuals from receiving preventive care and seeking treatment when a healthcare problem is developing, in other words, in the early stages. Many people will rely on the emergency departments for all levels of healthcare due to a lack of insurance. And I have told people over and over in my clinical group that the emergency room, the majority of the clients seen in the emergency room, it's just a glorified physician's office. Not to say that you're not going to see the blood and guts on occasion, but they are few and far between when you average out the type of patient that visits the emergency department. The cost of needed health care does become an issue when people are denied coverage, or they don't have health insurance as a benefit, or they can't afford insurance premiums, they lose health insurance, or they refuse coverage. A downturn in the economy increases the number of uninsured who are hospitalized and treated in the emergency department, where the bill is paid one way or the other by the community. Uncompensated care includes services that the hospital didn't receive full payment for. This is defined as free care or bad debt. Free services that the hospitals provide to clients who show that they can't afford to pay for their care are for many uninsured. And for many uninsured, free health care is the only option they have. This will result in huge yearly deficits for the healthcare organization. There's laws that do require hospitals to provide free service to those in need. And this is another reason, just for an example, why the emergency rooms receive such a high quantity of doctor-patient or doctor office patients, because if they go to the doctor's office requires payment, and the hospitals do not have to or are not allowed to require payment. So they can be seen in the emergency room because they can't pay, but they cannot be seen in a doctor's office because they cannot pay. These laws lack specific requirements, and they're really vague as to the amount of free care that hospitals have to provide. With bad debt, these are services that hospitals provide, and they expect payment, but they just never receive it. For example, insurance companies or patients that don't pay the bills, or insured individuals that do not pay their bills, as well as the difference between what the hospital receives for treating Medicare, Medicaid patients, or what it receives for treating privately insured patients. With government health insurance, again, there's going to be debate always about possible changes that Medicare and Medicaid will provide. Both forces in public and private healthcare agencies all the time let me back up. Public and private healthcare agencies really have trouble trying to keep up with the market. There is a need for cost containment, which is holding the costs within fixed limits. There's pressure from the federal government, insurance companies, employers, and consumers all along about keeping the quality of care, but providing it at a cost-effective manner. Nurses are part of that bottom line on how to contain the costs by reducing waste and increasing efficiency. This is what I have really been pushing some of you regarding. You have to be efficient in the provision of your care, not only with supplies, excuse me, but also with your time management. charging patients for all supplies, documentation for reimbursement, efficient and effective care, interventions to decrease the length of stay or prevent complications, and meeting the client's needs can be difficult, but it's all part of what nurses have to be certain that they are focusing on as they are providing patient care. Some reasons for the increase in healthcare costs are the costs of prescription drugs, medical malpractice lawsuits, and the development and increased use of medical technology. So the source of revenue for government health care comes from income tax and payroll tax. These are used to raise revenue to pay for programs such as health care. Tax cuts equaled a decrease in the money to these programs. For example, unemployment. There's not the payroll taxes, and there's less money spent, so the tax revenue is not as high. So there's a decreased raise in taxes overall. It's not voter friendly. So that results in a decrease in services, and that's not safe because we've all seen what cost cutting can do. The healthcare and the national economy. The national economy plays a great deal into healthcare economics. Physicians say entitlement programs don't pay for the actual cost. We send money off to fight other nations' issues. There's increased money to combat nursing shortage. Insurance companies keep increasing premiums. Baby boomers are such a large number of people, and many of them are not paying into the system, but they're starting to take money out. Being at war all affects the national economy. And cost of prescription drugs. Excuse me. The cost of a lot of the common drugs has risen twice as much as the rate of inflation. And after decades of soaring drug prices, employers and health plans expect employees to pay more for their prescriptions. Drugs are expensive in the United States because the companies can charge full price for the drugs. This includes the cost of research and development of these drugs. The continual rise in healthcare costs has resulted in annual increases in health insurance programs, premiums for employers. So the employers pass along the increasing cost of health insurance to their workers by decreasing benefits, or they don't even offer benefits. Insurance companies don't cover non-essential medications, so physicians are required to prescribe less expensive drugs. Large HMO plans will negotiate lower prices because they've got so many participants that it's not available to the government, so again, some prescriptions aren't covered. There are cheaper drug prices in Canada because of the Canadian government price regulation and the currency exchange rate. But anytime medication is ordered out of country, we have to be very careful because regulations regarding the safety of medications don't apply to them as they do here in the United States. So as we try to improve quality in healthcare, we look at continuous quality improvement that focuses on preventing problems or adverse events. The aims of the Institute of Medicine for improving quality in healthcare, they look at STEEP, STEEEP, which is safe. We avoid injuries. Timely, reducing the waits and delays. Effective, provide services to those who will benefit. Efficient, avoid waste. Equitable, the same care is given to everyone. And patient-centered is care that respects the patient's preferences, needs, and values. Excuse me. And with continued competency, care providers demonstrate continued competency. It's just required to maintain quality in healthcare. And as we improve safety in healthcare, there's a couple of different areas that focus on these improvements. Excuse me. The Joint Commission National Patient Safety Goals reviews adverse incident studies on causes of serious harm and death to patients. The National Patient Safety Foundation will improve the safety of care provided to patients and to eliminate healthcare errors. So how do we decrease the cost of healthcare? Once again, we look at cost containment, and we look at the LPN role in containing healthcare costs, making sure that you appropriately charge for supplies, document appropriately for appropriate reimbursement, use time efficiently through organization, do the job right the first time, prevent patient complications, and make sure that the patient's needs are met before yours. The major ways to accomplish healthcare reform are to do the following: allow incremental changes in the marketplace, enact comprehensive changes at the federal level. Unfortunately, this continues to be patched rather than fixed. These incremental changes have not solved the problems of access to the uninsured, and every aspect tends to make their own changes and not work together to make the changes. So incremental levels at the federal level. We've got the health insurance, the HIPAA, the Health Insurance Portability and Accountability Act, and Obamacare. At the state level, with the uninsured, the states are attempting to reduce their rising healthcare costs and cover their uninsured. At the local level, retail healthcare such as Walmart, Target, CVS, they've added clinics that are staffed by nurse practitioners or physician's assistants to treat some of those common health conditions. So comprehensive changes are changes that affect the healthcare system as a whole and not in a patchwork system. With the single payer system, the payment for doctors, hospitals, and other providers for comprehensive health care for everyone, regardless of past medical history, comes from a single fund. For example, Medicare is an example of a single payer system. The VA is an example of socialized health care in medicine. With health savings accounts, this does involve a medical savings account that allows people to save for medical expenses on a tax-free basis. It is linked with higher deductible health plans that have lower monthly premiums. The idea for health savings accounts is that patients will be more money-wise with how they use their medical services if they have to pay off the deductible of their annual health care bills from their accounts. Alliances are partnerships. They allow coordination of the delivery of care to contain costs among the providers of healthcare services, which gives the ability to deliver healthcare services more efficiently with fewer resources. All members of an alliance can buy supplies in quantity. They can share a computer system, and duplication of services and equipment is avoided. Consolidated systems are found nationwide. Reconstruction are strategies that are designed to decrease the cost of healthcare, at the same time maintaining the service and quality. This requires a radical shift in viewing how healthcare services are delivered. With managed care, there's control over the physician to decrease the amount of admissions and to watch the length of stay in order to get paid. With HMOs, there's an emphasis on prevention. The issues are delays in receiving diagnostic services, in approval of procedures. Profits are increased for the HMO, but they make dissatisfied participants. And preferred provider organizations are paid for like fee for service. They negotiate discounted fees and networks, but patients can still choose their provider. So, looking at changes in healthcare facilities. One survival strategy for acute care facilities is to continue to use unlicensed assistive personnel. They're cheaper than paying the RNs. Cross-training will allow the staff to be assigned from units with low census to units that have staffing needs caused by absences or increased patient census. Mandating nurse-to-patient ratios is an attempt to improve quality and service. Voluntary versus mandatory overtime is asking and requiring nursing staff to work beyond an 8-hour shift or their scheduled shift, which a lot of them are 12 hours these days, has been the method that a lot of facilities use in attempt to provide patient coverage during the nursing shortage. And patient-focused care is the most dramatic change in the way that healthcare is delivered. It's becoming more of the norm. Procedures are simplified and they're made more efficient. Charting is done by exception, and only the abnormals are charted to decrease the amount of time of charting. Electronic medical records involve recording all patient data in the computer and increases efficiency by reducing or eliminating the need for paper records, medical history forms, test request forms, drug prescriptions, written physician comments, etc. And finally, critical pathways is a cost-effective method that helps the patient reach discharge in the fastest time possible. The Joint Commission sets compliance standards for quality care and patient safety. It stresses the need to search continually for different ways that's going to help improve patient care. It's going to reduce the number of errors. And then how do we recognize and how do we fix these problems? Nursing licensure considers that an LPN is minimally competent upon receiving their initial license. Continued competence is assumed throughout the career. So when you receive your nursing license, it is telling everyone that you have met minimal requirements of competency to provide nursing care. Looking at change, we look at the victims. So we look at the change, and the victims look at change in a negative way. They fear the worst will happen because of the proposed change, and they feel very helpless in this situation. They don't willingly participate in the change process, and they allow change to control them. Survivors are the ones that resist the change, but they just go along for the ride. They claim the change will never work. And if their prediction comes true, they're going to be the ones that say, "I told you so." And navigators are the ones that feel in control of the situation. They're the ones that are confident and excited about the possibility of being part of the solution to the problem. They believe that they've got some control over change rather than being controlled by the change. So you have to develop a personal plan for change. You've got to understand that change is not necessarily a bad thing. You've got to remain flexible know what needs to be done and do it irregardless of the way that it's to be done. By doing this, you're going to learn to identify tasks that can be done more efficiently, and you're going to start working towards efficiency. Always, always be a role model for other nurses.